Now, Professor Christopher Dromey, Director of the Department of Communication Disorders, will introduce our lecturer, followed by Sarah Scott, who will speak, and we'll go to that point.
Well, good morning. Glad you could all be here today. This is going to be a very enjoyable presentation. I first got to know Sarah when she was an undergraduate student in our program a number of years back, 2009 I think that was, when she came to BYU as a single mom with so much energy and passion. It was unbelievable. Just a real thirst for knowledge. Sometimes we, as professors, hear things we don't like to hear from students that begin with, do we have to? That was not Sarah's approach at all. She wanted to learn for the sake of learning. She was very interested in all the things that we had that we wanted to share with her in the classroom, and it's just been a treat ever since to know Sarah. She's a highly skilled speech-language pathologist. Many people know little about our department in the McKay School, and you know that we do send SLPs out to the schools to help children with their communication disorders, but about half of our field works in a medical setting. And today we're going to learn about the work Sarah does as a medical speech-language pathologist to help individuals who've suffered a variety of different injuries and ailments, neurological conditions. She has especially developed her skills in working with adolescents and adults who have a variety of different brain injuries, spinal cord injuries, who have tracheostomies and other progressive neurological conditions. Sarah has served in leadership positions already. She graduated with her MS in 2014. I just had to look that up. I thought it had been longer because she's done so much in the meantime since then. She has been a director of a whole rehabilitation unit working with speech pathologists, occupational therapists, physical therapists, and others. Now she works as a clinical speech-language pathologist with enzyme therapies, and we are just thrilled to have her with us today. If you've ever wanted to meet Wonder Woman, here's your opportunity. Here she is, Sarah.
Well, that is a gross exaggeration, but that's okay. I'm really grateful for the opportunity to be here with you today. I spent 8 years, oh, Dr. Nissen. This is so fun. I can't even tell you. I spent 8 years at Brigham Young University, which truly is one of the finest universities in the world, being educated and invested in. I was taught by intelligent, gifted professors who really, truly changed my life. I want to address today how that education has prepared me to see everyone as unique and valuable, and to build them up and give them what they need to succeed in wherever they are at. As you learn here as students, if you are students, but it really never ends as adults too, I would just challenge you to ask intelligent questions, dig deep in whatever it is that you're working on to get to the heart of the matter, and be willing to both share and receive information to direct your choices. And then in whatever path you choose, you need to see people as people and love them, and do what you're doing not just as a job, but because you can change lives doing it. It matters. So I want to start by giving a little background information. In 2008, I was a single mom in Michigan. And so in 2009, I decided I was really going to have to do something to change. One of my sons had some medical complications and issues, as well as some learning disabilities and behavioral challenges. And so when you anticipate working full-time, going back to school, I needed a job that would give me good medical benefits to be able to take care of them. It's a little intimidating trying to provide physically, financially, and then be the parent for your children and want to do the best for them, but also not neglect them in the meantime. And so I knew I needed to make some sweeping changes in order to do that. And I decided I was going to go back to school. I had been at BYU earlier and knew that I would need to go back and pick a new field of study that would give me a different path. And so in anticipating that, I called my parents who were living in Sandy, Utah. I was in Michigan. and asked if I could come and live with them and go to school so that when I was not home, the kids could still come home and have family love and taking care of them so they wouldn't feel my absences keenly. And they agreed, which was very gracious and kind and a little bit crazy. So my dad flew out to Michigan, packed everything up, and with my 10, 8, and 4-year-old and the family dog and maybe 2 snakes, we drove across the country and to get a start. So I applied to the General Studies program. I had no idea what I was going to do, but I thought, well, I'm a non-traditional student, I'll apply to the General Studies program. And I made an appointment with the financial aid department at the administrative office and talked to a woman there, and she spent quite a bit of time with me. And she asked me why I was doing general studies and why didn't I just return as a full-time student in a major of my choice. And I said, I don't know. I hadn't even thought of it. I don't know why, but I hadn't. And so she encouraged me to do that. And I thought, that's a great idea. Let's set it up on the back end, but I don't know what to study. And so she suggested that I go and talk to the advisor about fields of study and options. And so I did that. And I met with a grandfatherly gentleman who was really kind and nice and spent a lot of time with me. I wish I remembered his name, but I don't. And he asked me a lot of questions about my life and what I was interested in and my experiences. And I had spent a lot of time in the special education classroom with my son who had an IEP. And so I had a lot of experience there and found it very interesting. And as we were talking, he said, have you ever considered speech-language pathology? And I said, no. And he said, well, I think it would be a good fit. It would take you 5 years to finish with the requirements for the bachelor's, and then you would have to do a master's. But 5 years is gonna pass anyway. You might as well have a master's degree. And he walked over to the file cabinet, got some papers out, and handed them to me with the requirements, and that was it. I read it, it clicked, and that was what I wanted to do. And so I was on my path of trying to become a speech-language pathologist. I felt a lot of pressure coming back to school because it had been years since I had done any kind of reading besides Agatha Christie and any kind of writing at all besides like notes to my children. And so that was a little bit intimidating, but I also felt really determined and filled with purpose, and I knew that the Lord would help me. Where I lack in confidence in myself, I don't lack in confidence in Him. I know He can make up for what we lack. But I felt a lot of pressure too, because I knew that in order to achieve my goal, I needed a master's degree, and the field of candidates is large and extraordinarily qualified. There's some really brilliant students here at BYU. And so that was intimidating. I knew I needed to work hard, which is okay. I don't mind work. I have several significant memories from that time during my undergraduate studies. Much of undergraduate learning is just listening to what you're told and regurgitating it, right? You don't think. You just hear the facts and information, you tell it back, and then yes, you now know things. And when I was in a class with Miss Lee Robinson, I remember there was just this moment where I thought, oh my gosh, she's asking me to think. She wanted to know my thoughts, my ideas, my interpretations, my conclusions about what was happening. And I relished that. That was an incredible experience to finally be to where I was getting to think about things and truly apply the knowledge and the memorization in a different way. I loved my classes, all of them. But I remember I'd started a class with Dr. Fujiki, and I was very eager to prove to him and myself that I could be successful. So the first exam was coming, and I prepared, and I prepared, and I prepared, and I was so ready. And I went to the testing center, and I took the exam, and I looked up at the board, and I got a D. And I was devastated. I just immediately did what everyone, actually I don't know if anyone else does, but I broke down into tears. I mean, I was bawling. And I walked across the campus, like directly, I couldn't even wait, and walked into his office. And I'm not gonna lie, because originally, when you're in school and you don't do well on a test that you've prepared for, whose fault is that? It's the professor's fault, of course. The test is a terrible test. And so I sat there just in tears. And who am I? Nobody. Just this like lowly undergraduate student who's in tears. And he spent over an hour with me. And he went through the test, went through my preparations, and helped me to understand how I would need to learn and study and grow and prepare the material. And with every subsequent test, I did better and better and better. And that learning, that instruction that he provided to me, like totally on the spur of the moment, and probably because he was a little worried about my emotional state, I don't know, but it really did translate into all of my other classes and studies. And I started to become successful in my schooling. So that focused, dedicated work that I was taught and how to work in that moment with Dr. Fujiki really carried through to everything else. I loved my classes on audiology. I thought I was going to go into the schools, and the schools are great, and I had a lot of experience there, but as soon as I started medical classes, that was it. It's so cool. You just have no idea how cool it is. And so I was in a class with Dr. McPherson, and it was the anatomy of the ear, which is fascinating. And he was showing some slides, and these slides were pictures of the inner ear and some infections and maybe some insects and other things, and there were a lot of groans and oohs and ahs and ugh. And he stopped, and a few giggles, and he stopped quietly and he said, if this is gross to you and it makes you laugh and cringe and turn away, like that's okay. But we are here to change lives. And so if that is how you feel about this, and maybe a different direction would be better for you. But we are here to change lives. And then he talked at length about what that meant. And man, I was in. I wanted to change lives too. Like that was it. And so that has just been burned into me. Like that is what we're here for. That's our purpose, to change lives. So at that point in time, my life was also changing. I met and then subsequently married my husband, and I inherited 2 beautiful daughters that are amazing. And so now in addition to the 2 boys, I had those girls. And the support of my family, my parents, my siblings, my husband, the faculty really sustained me. And time again, I felt my prayers answered and my capacity increased. Graduate studies were truly beyond my expectation. I mean, they were amazing. And our professors invested very, very heavily in all of us, which was constantly a surprise to me. I just don't know how they found the time and energy to do it, but they did. And I was worried about how I would balance the writing assignments, the research, the volunteering, observation, traumatic brain injury support group, clinic hours, group hours, projects, instruction, exams, taekwondo practice, scouting, piano lessons, homework, laundry, like all of those things. And it meant very early mornings and very late nights. I was not good once I came home at doing homework. Once I came home, I was mom. And then by the time I wasn't mom, I was exhausted and my brain didn't work. So I had to get up really early in order to keep up on things. But I never had to worry about traffic because I was always here early. So I had really cool opportunities. I got to work with Dr. Dromi on the research, experimentation, and analysis to do my master's thesis, which was eventually published in the Journal of Speech, Hearing, and Language, thanks to Dr. Dromi. But during that process, a lot of the articles that you have to read, the research that you do, and by the way, Dr. Dromi doesn't say, I want you to do this project. He was like, go to the library, look at all these periodicals, and see if something strikes you. You're like, okay. How does that work? But no, it worked, and he guided me through that whole process, which was really fun. But a lot of the articles, I had no idea what they meant. Like I would read it again and again, and I'm like, what is it saying? And my dad would read them with me, and we could discuss them and try to figure out what they meant. And then my husband was my editor. Everything that I wrote, I made him read and edit it and have it make sense, because a lot of times I'm a little dialogical, just write how I think and talk, stream of consciousness. But by the time I finished my coursework, externships, praxis, thesis, I was ready. I had been given this vast breadth and depth of knowledge, and I was prepared to go forth and serve. And also at Brigham Young, I received not just like a technical, but a moral background that I really would need to take with me to deal with the broad spectrum of physical and emotional challenges that the patients that we work with have and their families. So about that time, my husband and I were reading the book Leadership and Self-Deception. I don't know if any of you have ever read it, but it's great. You should. And the book is kind of a narrative style, but it takes place in the workplace, and it talks about how you need to see people as people. And it contrasts like thinking about me and my needs and what I want and deserve versus what other people's needs and wants, and that they are equal to yours, that they are people too, and really seeing everyone as a person. And in order to find my clinical fellowship position, I started cold calling skilled nursing facilities and hiring managers. And I got my first interview, and I went in for the interview, and on the desk of the manager was that book, Leadership of Self-Deception. And I was like, oh, I love that book. And it was the foundational mindset for the entire corporation. So that was a little bit lucky, and they offered me a job at the interview. Because I guess, I don't know, they figured that book was a good indication. So I had my job. For my clinical internship, the company that I was hired by, they have skilled nursing facilities, home health organizations, companies, and hospice, outpatient therapy. And I worked for them at a skilled nursing facility in West Valley City. And my clinical, if you don't know, when you do your clinical fellowship year, you have a supervisor. They do not have to be on site with you. There are certain requirements they have to fulfill. So oftentimes a clinical fellow is just thrown into a building and they're by themselves, and you have to figure it out, which would be challenging. But I was excited because my building had a full-time speech pathologist that was very experienced, and so my supervisor wasn't there, but she would be there. And after my third day, she left. And so I inherited her job and mine. So it was a little bit challenging, but really, really fun. And so there was a lot of work to do. Speech therapy is often very underutilized in skilled nursing facilities. People don't know and understand and take advantage of what we have to offer with regard to rehabilitation and healthcare in general. And so the same was the case there. So we developed a team of nursing, nutrition, kitchen staff, and speech pathologists to take care of our patients that were nutritionally at risk. So those that needed extra support to be safely and adequately nourished for a variety of reasons. We continually trained the staff with alternative communication, oral cares, aspiration precautions, swallowing strategies, texture modification, water protocol for hydration if they have a high aspiration risk. And then we also did a lot of education on just neurological diseases in general, and support groups for communication with those things. One of the many things that I love about speech pathology in general is that it has a huge scope, huge. And so just some of the areas that we evaluate, and each one of these areas triggers a different evaluation, are fluency. So most commonly people know stuttering, dysarthria. So if you have Parkinson's or cerebral palsy, and that's a motor speech disorder that you might be familiar with, voice. So like Diane Rehm and spasmodic dysphonia, voice disorder or nodules or something else infecting the voice, dysphagia, which is swallowing problems, apraxia, which is another motor speech disorder, expressive and receptive language, which is huge. We don't have time. Anomia is word finding. Aphasia, which kind of ties in with the expressive receptive language. Cognition, communication, and then auditory processing. Those are just some of the things that we assess. And so It's big, and there's a lot of opportunities. I've been able to work in the hospital setting, the subacute skilled nursing, home health, and outpatient. And so that's really fun. My favorite areas are swallowing. I think at the swallowing classes, not everyone thinks that's cool, but I was in the front like, oh my gosh, this is so cool. I don't know how everyone doesn't love this. And then cognitive linguistic function. By the end of my first year, when I finished my clinical fellowship year, I had worked on 4 different documentation systems, which each transition is challenging. And 3 different electronic medical records that nursing and the doctors use. And then, you have to learn about the medical payers and all of those things that it's changing, so it's not really practical to address it too much in your coursework. So all of that is new, so big learning curve. So from those initial, like my first years, I have some memorable cases that I want to talk to you about because that really brings to the forefront what we do and why. So I have authorization to share the pictures from 2 of my young friends, now friends, with you. And so we're going to be looking at a couple of them. But the first one was a 21-year-old male, and he was crossing the street and he was hit by a car. And he had really devastating catastrophic injuries. The entire left side of his body had been crushed. Femur, pelvis, ribs, brain. And so it was bad. He was in a coma for 3 months. Let's see. Maybe? Yeah. Thanks, love. Okay, so he was in a coma for 3 months. So what you're looking at is he's intubated, obviously, and he's on a ventilator. So he could not breathe for himself. He could not swallow or manage any of his secretions, saliva, anything like that. So they have to be able to suction any mucus, everything out of your lungs that just the act of breathing, coughing, things like that would get out of your lungs. Obviously in a collar, he was in a coma. He had a tube going in his nose. This is a nasogastric tube, so it just goes in the nose, down the back of the throat, in through the esophagus and into the stomach, and that's how we feed people. Short term, if they need to be nourished and they cannot eat, we do a nasogastric tube. And then if it's going to be longer term, usually the guideline is like 6 weeks or so, then we would put a tube directly into the stomach and feed them that way. But at this point, he still had that nasogastric tube. And so he, at the point that I saw him, will you advance? Thanks. At the point that I first saw him, he had been in the hospital for 3 months in a coma. 3 months. 3. And so you can see the entire left side of his body is just completely broken. Initially, when somebody cannot breathe for themselves, they intubate them through their mouth. But then if that is going to be something that is longer, then they do a tracheostomy and then they breathe through an opening in their neck. And so he eventually did have that tracheostomy. And so that was how he breathed at that point in time that I saw him. He had been trached. A lot of times people that have these traumatic intubations, when they have to do that, it damages their front teeth and it also traumatizes their vocal folds. So there's a lot of other problems that can be caused just by that. Next slide. And then he was transferred to us. And so by the time we got him, he was able to open his eyes and he could track you around the room. And that is all. That's it. So I did his oral mech exam, and he had hemiplegia. So hemi means half of your body. So the left side of his left side of his body was paralyzed. So arm, leg, his pharynx, his throat, his lips, his tongue, his palate, the roof of his mouth, all paralyzed. And then when I looked at the left side of his tongue, I'd seen a lot of hemiplegia, but I had not seen someone that was in a coma for so long because the left side of his tongue had completely wasted. So you have the right side that looks beautiful and pink and healthy and the left side that's just shriveled up. And so that was the situation that he was in. Okay, next slide. Okay, so I love him. So at any rate, there was a lot of work to do with him. So prior to the accident, he'd been working on his GED. He has autism, and he had a lot of sensory issues, and so school was difficult for him, and he was working toward that path still of getting his GED. And so over the course of the next 6 months, we had to go from no oral communication to, or receptive communication, to following one-step commands, yes, no questions, writing on a whiteboard with that hand, oral motor stimulation and exercises to get his mouth and tongue moving again. You have to go through speaking valve trials. In order to eat something, you have to close the valve that's in their neck so that it can build up pressure and you can protect your airway. But you actually have to go through a process of being able to tolerate that as being capped. We had to then do ice chip trials, just stimulate his mouth in general to try to get it to respond and move, and then puree trials. And let me tell you, if you have sensory issues and you're autistic, you do not love puree. So that was difficult for him, lots of gagging. And so he progressed through all of that. Worked really hard. And then he had to work on other things like voicing and impulse control and verbal communication and articulation and intelligibility. His left vocal fold remained paralyzed. It did not recover, and so he had to have injections to beef that up so that it could make contact with the other side and he could actually produce a voice. But I was able to bring him, you go to the next slide, so this is puree trials right here. And you can see here that his affect is like completely flat. You know, he doesn't have any emotion yet. But there's a cap on this now. And then he's doing puree, and then here he's eating pizza. So I was able, in speech pathology, we can be the hero sometimes, because when you provide someone their first slice of pizza or hamburger, you are a hero forever. So that is really fun. Let's go to the next slide. And so here he is learning to use technology again. And this is him walking across the stage getting his GED. So first he had packets that he needed to finish, and he was pretty close. But we had to look at the packets and figure out what is left and what are the skills he does not have in order to be able to do it, and then get those skills and then facilitate his ability to complete the packets. And so occupational therapy and physical therapy helped him walk across the stage, which he did with a walker. He now walks short distances without a walker, but he loves Marvel. Anything Marvel. He loves concerts, particularly 80s music, and he loves Comic-Con. Loves Comic-Con. Here he is holding his nephew. You can see him standing proud and erect next to one of the nurses. And then the next slide, Comic-Con. Yeah, so Star Trek and all of those fun things. And then it's really hard, especially for these young people, because their social circles are like nothing. The only people in their social circles are their family and the professionals that they work with. And so in this, we are out at an ice cream parlor. She's a patient that you're going to hear about next. She's a therapy tech. There's me and him, and she's an occupational therapist. And so I think when you become more than just a therapist and join that social circle, and then you can normalize things, like we're out at an ice cream parlor, it goes a long way to making progress with a patient. So that's that one. And then this is the cover of his page. He has a recovery page, but everything is going to be all right. Maybe not today, but eventually. And so I think he's very, very inspirational. And just about every day I get a message from him on Facebook. So he's really fun. Okay, next I'd like you to meet this young lady. And so she had a Chiari-1 malformation. So it's a deformity in the brain where it's actually like protruding down into the spinal column and creating pressure. And it's life-threatening because a lot of important things happen in your spinal cord and your spinal column. So this was a big deal. And so they had to do brain surgeries to try to alleviate that. She has type 1 diabetes, and so I don't know if many of us realize what a big deal that is, but it really, really is a big deal. And so trying to manage that type 1 diabetes with everything else happening was difficult. And then she developed hydrocephalus, which was very severe and compressed her brain. And so she had diffuse brain injury on top of the damage caused with the Chiari. And so this is her in the hospital. And actually, this is her in our building. That's our building out of the hospital. But she was my patient for a long time. She was apraxic, ataxic, dysarthric. She had cognitive linguistic impairment. She could not read or write. She had really poor frontal lobe function, executive function. So she had decreased insight, poor impulse control, sequencing, problem solving, self-monitoring, etc. So life was hard for her. She struggled. So 3 months inpatient, I worked with her, and then I worked with her for 6 months outpatient. And so this is the base of her neck and skull, and then this is from the hydrocephalus, she had to have shunts. That shunt is still causing complications for her. It's a lifelong battle that she has, but she's doing amazing and she's courageous with it. And so she had a lot to overcome. So the things that were really important to her, I mean, initially we co-treated with physical therapy. My rehab director is here, he's a physical therapist, but we co-treat with other disciplines a lot. People don't realize that. If you can't sequence steps and think safely and scan your environment, and especially when physical therapy has to focus on a lot of these major motor things, we co-treat together so that we can address the cognitive and they can address the physical, what the body's actually doing. So we had to work on transfers and safety after several falls that she had had. You want to click? Perfect. So again, we did a lot of social circle stuff with her, trying to expand that because young people who get brain injuries are depressed. It stinks. You know, it's hard not to be depressed about it, but we did a lot of things to try to expand that for her and help her feel normal. She had to learn to read. She had to learn to speak intelligibly. You could not understand a thing she was saying. She had to learn to interpret motion and language. She had to learn to plan and shop. This is a recipe card box that we made. So for therapy, it has got to be functional. That's what we do. I mean, you can do some things out of a workbook, but what is meaningful? Well, she could not make anything. She couldn't even make scrambled eggs. Okay, so let's come up with things that you're gonna make and make a recipe box. So that's what we did. That's her recipe box that she took a picture of. And then from there we did pathfinding. You have to be able to find it in the grocery store. Well, you don't realize that that's a really hard thing to do. So we did therapy in the grocery store. We had to prepare for it first with a map of the grocery store and where things are and what you need. So what you need is in what part, and pathfinding that whole thing. She had to learn to organize. She called me one day in tears because she couldn't clean her room. Actually, I think her mom called me first, and then she called me. And she literally could not clean her room. She could not organize that. It's too much. And so it was a great way to do therapy and work on that planning and sequencing and prioritizing and getting that done in small pieces. And then she wanted a pet. She wanted to be able to care for another living creature, which I think is a very normal thing. You know, we're human beings. We love animals and caring and nurturing. And so the first thing that we did, you want to go to the next one? Oh yeah, you've got to be silly, right? You know, you just can't take it too seriously. And then the next one. And every time she came, she wanted a picture with me, and she would post it to her social media. And so those are pictures that were taken and that she posted of what she was doing. So that's her fish tank that we set up in her room and structured so that she would be able to take care of it. And then again, this is the ice cream parlor where we're all out at the ice cream parlor. We filled out an application for her to go to the National Ability Center with her mom. We worked on that application. I love this. We're going to talk about this in a second. But she learned to ride a horse, care for a horse. She learned to rock climb. She learned to do archery. If you're not familiar with the National Ability Center and what they do, learn about them. They're up in Park City and it's amazing. They take people with brain injuries. So when you're a teenager and you've had a brain injury, you want to be able to do things like play a game, right? That's a very normal thing that you want to be able to do. Well, doing something in therapy and then actually being able to do it, or getting things that you train to generalize, is very difficult. That's really a hard piece. And so in order to support that generalization, this is her mom, and she would bring her over and we would play games. We had family game nights. And so these are my children in these pictures. And on multiple occasions she came and we would play games together and try to then, something that she had learned in therapy, get that then to apply to a bigger and more diverse but yet still supportive setting. Okay, and then the next one. And so this is another game night, and we played the game Headbands. And it seems a little silly, but that is a fun game. And we still play it at our group therapy at our building at Point Meadows. I have my speech group here. But we play headbands and do fun things like that all the time in group therapy. But the really cool thing about that was, so we prepped the game in therapy. We practiced it at my house with my kids. Then she and her mom played it at a family thing. And now this was her boyfriend. And on one of their first dates, they played headbands. So it was something she was confident in, she could do, and she was very successful in it. And then we'll go to the next slide. This is her at the National Ability Center. When she first started going there, she could not walk. So just to even have her standing next to it, she started with grooming. And then she progressed to riding and doing all kinds of showing in competitions. And then this is archery. If you're a bike rider, you can go biking up in Park City. So the days that I knew she was going to be at the National Ability Center, my husband and I would go bike riding and ride past where she was. So we were able to see her do archery and riding in her bike and her competitions while we were out for a bike ride. So it was really fun. And then this is her and her boyfriend, who became her fiance, who became her husband. And so again, really fun to see. And we went to the bridal shower. And this is their engagement photo and bridal photo. And then the next one, 9 months ago, baby makes 3. So she had a baby. And that baby is now 9 months old and is very, very darling and has complex medical challenges that her mama is very capable of handling and taking care of. So that's the next slide. There she is. And we'll just keep that one up because she's cuter than any of us are, and you can look at how cute she is. I'm going to give you a couple of other just short case studies. This is the end of our slides. I don't have slides from the other patients. We had another gentleman who had cancer, a massive tumor at the base of his tongue and throat. And so he had had surgery, chemotherapy, and radiation. And when I first went to meet him, he had a feeding tube. He would not talk. He would not turn the lights on. He would not get out of bed. He would not bathe. He had been told that he would never eat again. He would not do oral cares, he would literally not do anything. And he had just completely shut down. So we had to really, really work to support him and get that going. He had the hard thing when you work with people is it's not just what you're seeing that you have to cope with. They are a person with their own personality and lifetime of habits that you have to factor in or you are not successful. But he had struggled throughout his life with mental illness and really perfectionist ideas. So it was perfect or it was nothing. And so since it couldn't be perfect, he was nothing. And so that was where he was. And so we had to really start small and get through that. And so we had to start with, basic oral care, basic engaging in life. And then we were able to progress to exercises and then trials. And he discharged from the building. You would have thought he was never going to go home and anywhere. He looked like he was going to die, but he went home. His brother helped him. He went home and he was eating part of his food and walking with a walker, but eating part orally and still getting supplemental feeding through his feeding tube. But then he came back a few months later, feeding tube removed, walking without a walker. His brother was no longer staying with him and he was independent for all of his complex activities of daily living. So, we get to change lives. This is really cool that we get to do this and have this opportunity. About, I don't know, a couple of months ago, I got a call from a speech pathologist at Huntsman, and he had had another recurrence of cancer, but they had caught it really early. And the speech pathologist called me, and she was kind of laughing, and she said, well, he's insisted that I call you to get the recipe for working miracles. So I thought that was a little bit funny, but it's not really a miracle, but we do get to change lives. So after 3 years working at that skilled nursing facility, the director of operations approached me and asked me if I would go to be the director at another building. It was licensed as a psychiatric hospital that had 110 beds. 90 of those long-term care, but for people that had acuity that required hospital-level care. And then 20 of them skilled nursing beds where people are coming, getting better, and then going somewhere else. And the building specialized in degenerative neurological diseases and dementia. So I was a little bit apprehensive about going to be the director there. First, I just wasn't sure I could do it. I wasn't sure that I wanted to do it. I wasn't sure that I wanted to be going specialized into like dementia setting and what that would do to my career. I wasn't sure that I could handle it balancing being a mom and extra responsibility, and so I was a little nervous about it, but I did it, and I'm really glad that I did because, again, it was another catalyst for a lot of growth over the next 3 years. So in this facility, if you had someone that was 95 years old, had Alzheimer's disease, had diabetes, had diabetic neuropathy, so they can't feel their hands and their feet, had hearing loss, vision loss, and then fell and broke their hip or had a stroke, that is who we got. So very complex medical patients. A lot of times who are kind of dismissed to not being able to rehabilitate and not having potential. A lot of times too, when you have someone that has a little bit of dementia and then something happens to them and then they go to the hospital, all of a sudden they get stamped as like severe sudden onset dementia because delirium postoperatively when you have dementia and then you're adding different medications occurs very frequently, and teasing out the delirium versus the dementia, what is acute and what is not, and then also controlling the behavior because they're trying to hit everybody and screaming and wanting to walk around when they aren't even supposed to put any weight on their leg, things like that. So people will often come to us with restraints, like they have been in the hospital restrained, they've had one-to-one supervision, or they've been medically restrained, so drugged so that they can't act crazy. So it requires a lot of a special lens, maybe is the right way to say it. So I grew to have a huge passion for this population. When I got there, only one of the long-term patients was on therapy, one. Now the national average would be at least 10%. And in a specialty hospital, it should be more. So it was a very underserved population. And so my vision was that everybody there, and most of them can't advocate for themselves, but that they would have the opportunity to have the services that they needed and deserved. So, for example, if they had a change in cognition, if they began falling, all of a sudden, they used to assist with the transfer, and now it takes 2 people to pick them up and move them. They can't maintain their position in a chair. They're getting bed sores or position sores. They start pocketing their food. They stop eating altogether. They stop feeding themselves. If they can't communicate or they can't access social communication or functional communication, they need to be evaluated by a therapist, and they need to be assessed for opportunities for improvement, modification, or adaptation. So that was really fun. As the mother of a special education student, I do have a couple of pet peeves, and I will share those with you. The thing that I would get a lot is, well, Johnny doesn't pay attention. Johnny failed the test. Johnny didn't do their homework. Well, no duh, Johnny didn't do it. Like, this is Johnny we're talking about. Like, I already know that stuff. I don't care. I want to know why. Why didn't he do it? What did it look like? So if he's disengaged, what does that look like when he's disengaged? If he failed a test, how was the test administered? And what did the test look like? Did he do part of it and then leave the rest blank? Did he put A for everything? What time of day was it? What had happened just prior? What strategies did you then use and implement to see if you could support the function? I want to know why it happened. So what occurred? What was the antecedent to it? You have to think. So now transitioning back to our scope of practice and field, if you see things like restraints used, medically restrained, sudden onset dementia, no potential, like those phrases are exciting to me. Not that they're happening, that's terrible that it's happening. But there's a lot that we can do. And I always believe that we could help. And being a therapist is like being a detective. And so there's a lot of flags that you have to do when you do a chart review. Chart reviews are one of my favorite things to do. But you have to watch very closely for things. Every once in a while it's straightforward. But truly, with the elderly, not very often. Almost never. So you have to watch for flags like repeated urinary tract infections or dehydration, weight loss, falls. If you simply treat those symptoms and then send somebody back home, you're ignoring what it is that led them there to begin with, and you're setting them up to fail. So you have to ask yourself, why is it occurring? Because the possibilities are numerous. For example, have they had a decline in their ability to perform those basic activities of daily living? Have they had a change in insight, in the ability to know and understand that they need hygiene or hydration? Do they have a fear of incontinence? A lot of seniors do not drink because they don't want to have to pee. So they don't drink and they get urinary tract infections. Do they have decreased access to food and drink? Are they afraid of falling? Do they have depression? A lot of times seniors get depression and it goes ignored. If they're losing weight, okay, they're losing weight. Well, why? Why are they losing weight? Oftentimes you can see dysmotility of their digestive system. They can have a stricture. They can have loss of appetite, again, from depression. They can have decreased access to food. Happens all the time to seniors. They can have a change in insight, a change in dentition. You have no idea how often that happens, especially in some of the poorer areas. People lose their teeth and now all of a sudden they can't eat and nobody catches it and they're losing weight because you keep putting things in front of them that they cannot eat. Or do they have dysphagia, a swallowing problem? Do they have a compromised respiratory system? So now they don't have the activity tolerance. It's literally too exhausting to eat because they have something going on with their respiratory system. So each case has its nuances, and these are people, real people, some loved and some unloved, but they all deserve of us asking the question, why? Why is it happening? So I had I have two more examples that I'll share with you. How are we doing? Okay, we're done. But two more examples, really, really fast. So I had one patient, she had an autoimmune disease. So she was the only child of immigrants. And so they moved here and they had passed away long before. And at one time she was living in an apartment. She had a ward and neighbors and people who cared about her, but she became ill. She could no longer go back to her apartment, so she went to an assisted living. And then she became ill again. These are chronic illnesses that people have, and so she went to a different assisted living facility. And then she became ill again, went to the hospital, and then was discharged to long-term care, to me. And so now she has nobody. She is truly alone in the world. Nobody that ever knew her, that worked with her, that was her neighbor, her Relief Society sister is there or reachable. And so the referral came to me because she was losing weight. Okay, I had been told that she had zero rehab potential, that she was aggressive, agitated, was screaming constantly. And so I went to take a look at her, and it took about an hour and a half of interview, chart review, and assessment with her before I came to a startling discovery. And that was that she was deaf and blind. So her progressive neurological disease had caused the loss of her vision and the loss of her hearing. So she's in a bed or in a chair. She has to go to the bathroom. She cannot get there. She is soiled. She cannot get someone to listen. She cannot see who's around her. She cannot find the food. She cannot get a drink. She can't do anything. And so when you go to see her and the caregivers are moving her around and yanking her to change her clothes, she can't see you and she can't hear you. So what is she going to do? She's going to grab you because she's terrified. Okay, so she's not behaving poorly. She's behaving predictably. And so it was not difficult then to figure out what to do. So we got an amplifier for her, and then we figured out that if we modified and used certain words that didn't have a lot of high frequency sounds, she could hear them great. But it had to be short, it had to be certain words, and you had to talk in a certain volume, and then she had an amplifier. And now all of a sudden she knows what's going on. Now we have to position her food a certain way. We have to take her to the dining room, and you have to cue her as to where things are. Now she can eat. Her texture needed to be adjusted because she did have a little oral dysphagia, but if you adjusted the texture, she could eat and swallow and chew everything just fine. So then she was a candidate for physical therapy and occupational therapy, and she started being able to dress herself, and she started being able to move around the building. So she was delightful. She was brilliant. It was really, really fun. That's everything to give somebody. A few months later, she became acutely ill again, and she went to the hospital. And I just went to visit her as a friend. I'm going to just get rid of the rest of this because we're done. But I went to the hospital to visit her, and I brought her amplifier. And when I got there, the doctor told me that she was dying, that all of her organs were failing, but she was a full code. So if you don't know what that really means, it means that when you die, and you're going to die, they're going to do CPR, and they're going to crack your ribs, and they're going to intubate you, and probably chip your teeth, and do all kinds of like really horrible invasive things that if you're going to live and you have the potential, like, okay, fine, the result is okay. But if you are dying, you know, her body would sustain the imaginable, right? So I was able to put her headset on her and communicate what the doctor was telling her to her, and she was able to tell him that she was ready to go. And so, guys, this is everything. It really, really is. Like, people matter. So in whatever avenue you choose to pursue, speech pathology is the coolest, but no, I'm kidding. I'm really kidding. McKay School of Education, all the way, equal. But whatever you choose to do, you have got to see people as people. You have to love them and care for them and get to know them, and you have to think about what's going on. I'm eternally grateful for the support, the nurturing, the mentoring that I received here at BYU. It has changed my life. Now, the interesting thing about all of this is, like, here I am, like, oh, we change lives, we do all these great things. And it's a little bit of a crock and self-serving because in the end, they are the ones who change your life. You come off way the winner in this game here. And so they will change your life. So that is what I have prepared for you. I talked way too long. If you have any questions or you want to talk to me, I would love to talk to you. You can say I have no problem talking. And thank you very much.